The broadcast is now starting. All attendees are in listen-only mode.
This is Danny Bobrow, President of AIM Dental Marketing, welcoming you to this installment of the Practice Perfection web-based education series. Today's presentation is entitled, Double Your Hygiene Production in 9 Months Guaranteed. I'm super excited to bring this presentation to you because in many ways it represents the culmination of an odyssey, the last few years at least of which I was privileged to be an observer. Alexander Slepak, MD, focuses on integrating dentistry and medicine to deliver a truly comprehensive approach to patient care. He is a graduate of the Temple University School of Medicine, holds bachelor degrees in biology and psychobiology, was the driving force behind the Scottsdale Center for Dental Medicine, and brings a unique perspective to the business of oral systemic practice. I met Dr. Slepak at the annual meeting of the American Academy of Private Physicians in 2011 and knew then that this was a man to watch. He has the distinction of being the first physician to join the American Academy of Oral Systemic Health, which by itself speaks to his commitment to and early adoption of the oral systemic model for whole body health. He is a true visionary whose experience owning and operating healthcare organizations gives him a unique and valuable perspective on the business and practice of oral systemic health. Dr. Slepak focuses on integrating dentistry and medicine to provide the most comprehensive approach to patient care. We are joined also today by Dr. Reed Winnick and his lead hygienist, Tammy Kohlschmidt, whose Midtown Manhattan practice follows Dr. Slepak's protocol. Both will, later in this webcast, share their experience with implementing Alexander's protocol into their practice. Now, before we get to today's event and very special presenter, I want you to know that Practice Perfection webcasts run for around 90 minutes. While attendees are in listen-only mode, we invite you at any time to submit your questions or comments using the question button on your screen. We will allow time following the presentation to get your questions answered. If we do not get to your question during the webcast, we'll see that they're answered shortly thereafter. Attendance at this presentation entitles you to receive 2 hours of continuing education credit. Shortly following the webcast, you will be emailed a brief survey with instructions on how to receive your CE. Participants are cautioned about the dangers of incorporating techniques and procedures into their practices if the course has not provided them with adequate clinical experience to allow them to perform it competently. And now, it is my pleasure to welcome my friend, Dr. Alexander Slepak. Hello, Alexander.
Hello, Danny. I want, first of all, to thank you personally and Virginia for inviting me and helping me with this presentation. I want to warn every listener that this is my first rodeo. This is my first webinar. So if anything goes wrong or I push the wrong button, then excuse me, and we'll continue when things will happen. Having said that, Danny, I do not see my screen.
Okay. I just made you the presenter. That was, you should be asked to accept the ball, as it were.
I did accept the ball. Okay. Let's do it again.
You should be able to see, we should be able to see it. All I'm seeing is it appears that you haven't accepted it, but you say you did, correct?
Yes, I did.
Yeah, are you clicking, did you click show my screen?
Yes, I did.
All right, let me take it back for a moment. And we'll do it again because, hey, this is the magic of technology. Wonderful when it works. Not so wonderful when it doesn't.
Here we go.
Just a moment. Stand by. Okay, Alexander, here it comes again. It's in your court.
Okay. Show my screen.
Right now, and this happens occasionally too, I'm seeing a black screen. Virginia, are you seeing Dr. Slepak's first slide?
Yes, I am seeing his slide.
Okay, Then take it away, Alexander. You're all set. You're good to go.
Okay, fine. I have to express my gratitude to a very special person before I start. Her name is Jeannie Godet. She is a very talented, experienced hygienist, my friend and my partner in developing periotherapy protocols in Scottsdale, Arizona. This work will not be possible without Jeannie and her contribution. Now, we know that lately, within last, I would say, 5, maybe 10 years for those who are involved, more and more we hear about the connection between the oral systemic health and the overall general condition of our body. But not knowing who constitutes our audience, I would assume that most of us by now heard or being involved in some way or another into oral systemic health. We know that the healthcare spending right now is a runaway train. The expenditure on treating diseases surpasses any budgetary expense today, not counting, of course, the defense and some other issues of security. But unfortunately, we're still treating diseases. We're not treating the health of the patients. And it's interesting to know that the nomination of healthcare, we actually have disease care. The healthcare will be only possible when we will start paying more attention and allocating more funds to prevention of any kind of ailment or disease. As a member of the Academy of Private Physicians, I see the trend already moving in the right direction, and the insurance companies are changing their approach because it makes an economic sense. Under the Affordable Care Act, or as we know it, Obamacare, now there are more and more emphasis not only to make sure that insurance companies are accepting patients with pre-existing condition, because before that, for the insurance companies, that was a natural barrier to save money and limit the expenses. They were not allowing pre-existing condition patients to be treated or get coverage. Now that under new laws they have to, the only way they can save money is to focus on prevention rather than treatment, because treatment is not getting cheaper. So when we talk about bidirectional relationship between oral health and systemic complications, we have to start thinking that in the mode of prevention, there is always attention to the source of the problem. And more on the medical side, physicians realize that the source of many infections in the body affecting other organs comes from oral cavity. And it's very logical because it's a major portal not only of entry of nutrients but also entry of pathogens in our body. Regarding the publications and scientific research, there is an enormous amount of data. Some publications are conflicting, others are very to the point and really shedding light on the development of this new science. And I call it new science because historically in medical schools, training physicians, the oral pathogens or any kind of problem in the oral cavity was not really addressed because it was a domain of the dental community. But now more and more publications are surfacing related to oral cavity, not only in dental literature but also in medical research. The interesting fact is, and we experienced it at Dr. Winnick's practice in dental practice in New York, that more and more medical specialists are requesting pre-authorization before major surgeries or major invasive procedures. Orthopods, surgeons, now understand that the seeding of the site of surgery can be from the oral cavity. They understand very well that gram-negatives anaerobes can flourish in a scar tissue, well, actually not in the scar tissue, but in a vulnerable area after surgery. The supply of blood and erythema around the area makes perfect environment for bacteria to set in, especially anaerobes. The same goes for surgical procedures and invasive cardio procedures. Also, a lot of cardiologists are right now requesting clearance from the dental community. There is evidence that fertility physicians are also trying to pay more attention to prevention and treatment of women prior to initiating fertility procedures that are very costly, and the loss of the fetus is not only loss financially for the woman and the family, but also it is a very strong psychological stress. So they are paying attention, trying to prevent any infection. The same goes for oncology patients, patients on chemotherapy whose resistance goes down. They're very vulnerable for any kind of infection, and of course oral infection is very aggressive in patients with decreased immune function. And I don't think I have to tell you about diabetic patients. It goes without saying that there is a lot of research right now on connection between diabetes and oral pathogens. And talking about diabetes and oral pathogens, we know that it's a two-way street basically, because with advancement of diabetes, more prevalent infection happens in the oral cavity because the resistance goes down and the functions of the body goes down, plus the increased glucose level in blood and saliva is a good nutrient for the bacteria development. We also know that very similar happening in rheumatoid arthritis, for example, with a chronic period. As the system acts up in other areas of the body, the inflammatory response also takes care in the oral cavity, in the gingival area. The Crohn's disease, for example, the inflammatory bowel disease, again, very similar in the nature of two-directional and co-influential morbidities. Inflammation in the viscera and in the intestinal lining contributes to overall inflammation in the body and in the gum area. In terms of the professions, the issue coincides. There are two things that we have to understand. The proper treatment cannot be ignored with a soft tissue inflammation. We cannot just do the prophy on the patient that comes with the evident periodontal disease. We know now that there are tests available to not only identify pathogens, but also to properly know the makeup or genetic makeup of the patient. We also have to know what kind of bacteria is involved relative to other species in the oral cavity, so the pharmacological treatment will be adjusted accordingly. especially in the patients with the medical history. If the medical history is positive in those patients, then we have to identify the pathogens and we have to do it. So professional responsibility becomes a big issue in fighting the oral disease. The other very important issue is the legal issue. And I've been talking to several attorneys already that bringing that to the surface. Keep in mind that they're large corporations, law firms that specialize on malpractice insurance. And if we are reading those articles and we follow the research on pathogens and its influence on the body, you can rest assured that those attorneys are also hiring specialists who are screening that literature. Two issues to consider: morbidity, that is, if somebody has underlying medical problem and that problem exacerbated by the oral pathogens that are not treated properly by the dentist, then dentist might be in a not very comfortable position if attorneys will start digging in. The other is, of course, unfortunately, mortality cases, and we know many instances when post-mortem the pathology was done and there were evidence of bacteria either in lining of the vessels or on mitral valves of the heart. So we know that there is science today that can identify either oral bacteria antigens or even live organisms post-mortem. So that is also a very big thing to think about because nobody wants to be accused of neglecting the patient, and inevitably that neglect led to demise of the patient. Let's just take a pause and think about periodontitis is basically inflammation of the soft tissue. It doesn't matter where the inflammation of the tissue takes place from the medical point of view. What matters is the process, the destruction of the tissue, the systemic immune response, and detrimental effect on organs and tissues throughout the body. So pathogens must be eradicated, or at least brought under some level of control. Inflammation must be reversed and extinguished if possible, and the entire system has to be restored and protected. Short of that, we're not treating the inflammatory disease. And again, I address it and I look at it from the medical point of view, not from the dental. If there is an infection, it has to be treated, just like in any other medical infectious disease. And again, very often we hear on presentations when people compare the size of the lesion in the oral cavity to the size of the hand, or some kind of visual measurement. But I want listeners to understand that if we have in a periodontal patient constant but microscopic dripping of the blood from the gum area, if we have a patient with chronic bleeding on brushing or chewing or with any kind of manipulation in the mouth, then we have consistent hemorrhaging. And if you compare it to the polyps in the large intestine, people undergo colonoscopy because they become anemic, and doctors are looking for one little spot somewhere on the polyp that continuously drips blood. Now, imagine that those physicians don't even think of some other area that also can continuously drip blood. So it's very important for us, again, look from the medical point of view. If we have a chronic periodontal patient, how much blood are they losing with every swallow?
Sorry to interrupt, Alexander. Is it a question of how much or whether it's present almost at all? It seems to me, and you're funny, you were anticipating I was going to comment about the analogy of the size of the lesion being like on the palm of the hand, and if you presented to a physician with that, they wouldn't say, let's watch it. They would bandage it and treat it and try to, reverse it, stop the bleeding. So I guess the first thing is obviously for the dental practitioner to view it as a medical problem, and then of course the challenge is getting the patient to understand that that's what it is. But in essence, what you're saying is it would be like another physician working with another body part, an organ, saying, yeah, we're seeing bleeding in that organ. We'll just watch it for the next several months until you come back and see us. They just wouldn't do that.
No. And again, very often women diagnosed with anemia, and very commonly the first response from a general practitioner will be, why don't we do colonoscopy and look, maybe you have internal bleeding. Or let's go to OB/GYN and check, maybe you have some bleeding in the other area. But
bleeding is bad.
But no physician will think, let's go and check your gums. Maybe there is a bleeding, constant bleeding, drip by drip.
Mm-hmm. Sure.
So that's the point of comparison, I think.
Okay.
Now let's talk about, I want to compare without any insult intended, but basically based on my experience in Arizona, where I had a practice and worked in a dental community. Of course, we all know that there are progressive dentists and there are dentists who just trying to make a living, and not everybody has the top of the line equipment and top of the line clientele, etc., etc. So I'm not judging here. I'm just trying to compare the regular hygiene department versus periodontal therapy department. And we intentionally do not call our hygienists. They are periodontal therapy specialists. And we don't use the word cleaning because usually the janitorial services clean windows and floors. So we provide therapy. The protocol design, and I don't want to go into specifics now, but protocol is designed in such a way that it's applicable even to quote-unquote healthy patients or patients with gingivitis. It's the approach, it's the thinking that's what's important rather than how you start or where you start. So let's look at the left side, and it's a hygiene department. In many practices, in your regular general practice, hygiene department is an ancillary part of the practice. It's just something there, hanging there, to help in a way, but it's not the main part of the practice. Very often, dentists look at the hygiene department as the source of restorative dentistry. They go evaluate the patient. They found lesions. They found fractured restorations, and that's the source of their income through the referral or exam from the hygienist. Other dentists look at it as a necessary, required element of their practice. In other words, ADA requires it, so they do it. It's a standard of care. What we are trying to do, and well, that's what we're doing in New York right now, and that's what I had in Scottsdale, in Arizona. The periodontal therapy department is an independent healthcare department, just like any other, like aesthetics, like surgery, like endo. It's a self-sustained, functional part of the practice. It can be, in some instances, a major source of patient referrals to the practice. Because more people, if you think about our society, and there are, again, many sources, starting with CDC and ADA, to other organizations, saying that in our population about 70% or 75%, depending on the stage, of the population have periodontal disease. And yet, if you look at the general dental practice, you don't see them doing 75% of SRPs versus trophies. In a general practice, majority of work by hygienists are trophies. So this is something strange, and nobody pays attention to that. Periodontal disease have to be treated. If we have 75% of population with periodontal disease, then 75% of hygiene department has to be periodontal therapy, not prophy. The other thing is the only venue of interdisciplinary cooperation with medical community. Again, you cannot talk to medical doctors regarding crowns or bridges or any other restorations. But the issue of periodontal disease, that's something that you can find the common ground with medical community. That's when you can talk to physicians, not about the crowns and bridges, not about endo. This is the only venue to get involved with the doctors, with MDs. Talking about independent healthcare department, hygienists are doing comprehensive clinical assessment of the patients by in their chairs. That means that the approach is very similar to what nurse practitioners are doing in medical setting. It is comprehensive. They do very thorough analysis of medical history. They do physical exam. It takes usually an hour for hygienists just to evaluate the patient. The next one is individualized periodontal treatment planning. Again, hygienists are trained to set up the treatment plan depending on the level of involvement in periodontal disease. And again, it's not going just by stage. There are a number of variables that have to be looked at and decide what is the proper treatment plan for that individual. Of course, it is done in cooperation with the dentist. Hygienist by law cannot sign on a treatment plan, but believe me, hygienists can think as well, sometimes even better, than the dentists in many practices. The next is scheduling of periodontal patients and procedures. Again, hygienists in our practice are scheduling patients themselves. They determine how much time they will need and what the next step in the treatment will be necessary. They adjust the treatment plan based on the results and progress that patients make. That's another.
You're really talking about empowering the hygienist to take much more of a lead role in the management and treatment of the patient.
We treat hygienists as clinicians, Danny. Very well trained and experienced hygienist can perform not less than well-trained associate in your practice.
I think that's an important point to underscore.
They have the same level of intelligence. They establish very strong and good rapport with the patients. Patients trust hygienists because they spend more time with them. And this is only logical that they must be empowered to provide the proper periodontal care.
And I imagine that that's music to the ears of many hygienists. I know from personal experience many hygienists are frustrated at not having the latitude or the authority to do what you're talking about, and so I imagine that you know, there are reasons for that. There's old school thinking, and maybe the dentist doesn't feel that the hygienist is qualified, and it sounds to me like I know that many of them are, and it sounds to me like maybe this is another way that you're bridging a gap of understanding so that there's mutual respect within the office, the practice, as well as between the patient and the hygienist. I think that's really important to point out.
Right. We're not trying to develop animosity here, or on opposite. We're trying to help dentists to deliver proper care to their patients, utilizing specialists in the area. And who are better partner for the dentist than a hygienist?
They're periodontal specialists.
In my mind, they have to be treated equally. Just like nurse practitioner is treated in a medical setting.
Sure, and terminology is important. I love the term periodontal therapy specialist as opposed to hygienist or cleanings, because you're right, janitors clean, hygienists treat.
The other thing is, Danny, the last point here on this slide, follow-up and home care health coaching. And I know that you know very well about health coaching. So after the visit, hygienists are following up with the patient on the phone, discussing their progress on home care, coaching the patient. The phone calls are regular, systematic. They develop good relationship with the patients. Patients anticipate the call. The cancellations are going down. Compliance with the treatment goes up. The bond is established, and this health coaching by hygienists is one of the key vital elements of the protocol. Okay, now we are moving to the major source of patient referrals to the practice. That's an interesting one because we know that referrals to the practice can be done by targeted marketing of the gum disease through websites and landing pages and specialty groups, etc. But very important is to develop internal marketing. Internal marketing is very easy and much less costly, and I'm sure that your listeners, our listeners, heard that before, but I want to stress that fact, that if you provide such care to the patients and you treat them without necessary surgery and you achieve results, these people will gladly refer their family members, coworkers, and anybody else that they talk about. The other thing is that coming from such office, they brag about their experience in the practice because now they finally got a treatment of something that was bothering them for years, and now they found a hygienist who understands. So this internal marketing is very important in this practice. Referrals from physicians. Again, cross-referral. The more you connect with the doctors, MDs, and you refer your patients to them, the more they will refer back to you. And I don't want to dwell on that, but we can talk about cross-referral sometime later. The only venue of interdisciplinary cooperation with medical community. And here are the key steps. First of all, you initiate contact by submitting collected information and results of the tests. So all these biological tests that you do, you send them to the doctor. Do not be afraid that they are not familiar with that, because when you start sending it to them with the follow-up letter, they will start paying attention and they will start reading it. Provide specific literature relevant to each case. In other words, if you have a diabetic, provide specific literature together with the tests. If it's a pregnant female, then provide literature related to periodontal disease and pregnancy. The next step is provide results of therapy, keeping patients, physicians in a continuous line of communication. That's very important. As hygienist advances in the treatment and gets better and better results, if you have a patient that has rheumatoid arthritis or some other concomitant disease, it will help physician to know that the source of inflammation is going down, the burden on the system goes down, patient oral cavity improves, therefore they can adjust their treatment on their side. The next step is provide synopsis of patient's maintenance and post-treatment condition. Again, if patient comes back under the protocol and hygienists are following their development and their maintenance, send a letter to the physician so they know that the patient is taken care of. If there is any flare-up in a patient with existing medical condition, hygienist will be the first to pick it up and send a note to the doctor, advising doctor to see the patient immediately. And lastly, train physicians to recognize symptoms of periodontitis.
Just wanted to briefly interrupt for a second. I'm sorry, but it occurs to me that as you're doing this, I just want to be sure that everybody listening understands that you're not just offering advice and then leaving it to our attendees to decide how to do this on their own. They certainly can, but I just want them to know that Health Integration System offers this, and we'll hear more from one of the offices that you're working with. But and just clarify if I'm mistaken, but Health Integration System provides the literature and the training, does it not?
Okay, let's talk about. I'm looking at the clock and I'm running out of time, so I'll fly through this. This is the case of Anthony, one of our patients, and we do the DNA analysis of the patient always with periodontal disease. Reason being, we want to know if patient is susceptible to inflammatory response based on genetic makeup, and for the lack of time, for those who are not familiar with oral DNA testing, it's the whole lecture on its own, but different interleukins involved in inflammatory response can be activated more or less in different individuals depending on genetic makeup. So this individual, Anthony, has a high periodontal inflammatory risk, meaning that in his makeup, the interleukin-6 produces more protein that triggers the chain of events. It's a domino effect in our system, and this is one of the factors involved in the process. This is the Periopath test on Anthony before the treatment. And here we can see that the test divided the pathogens. Obviously, these are not all the pathogens. There are hundreds of pathogens in oral cavity, but these are the most culprit in developing periodontal disease, and they're divided in high risk, moderate risk, and low risk. Treponema denticola is one of the bad guys, and you can see that on the left side it is elevated. And by the way, on that graph, DL stands for detectable level. It doesn't mean that we don't have others, or Anthony doesn't have others. It means that the test is set up, the plank is set up that below that level the test does not detect them, but they're there. There's nothing sterile in our mouth. But when we reach the threshold, that horizontal line, it means two things. It means that the contamination of the oral cavity with certain pathogen is beyond the comfort level. And the second, it means that it's at the level that it most likely inflamed the tissue to the point where it penetrates systemically. In other words, it now enters the bloodstream and seeds the entire body. So the threshold lines are very important. Now, Anthony does not have very high level, but keep in mind he has high tendency for inflammatory disease, which means that on any other patient with this makeup of pathogens below the threshold, they will have probably very moderate inflammatory disease in the mouth. But because Anthony is predisposed, this amount of bacteria can really pronounce severe periodontal disease. And this is the report after the treatment. Again, this is before, and this is after. The high-risk pathogens are gone, the moderate-risk pathogens are in check, and low-risk pathogen below. By the way, about low-risk pathogen, they're opportunists. Whenever you change the makeup of your flora in the mouth, the turf is always preoccupied by somebody or something. So when one goes down, very often the opportunities go up. This is Anthony's chart before treatment, and we can look at Anthony is 73-year-old. On the upper left and lower left, you can see pockets of 4 to 5 millimeters. And if you look at the after treatment under protocol, by May of this year, we have 3 millimeter pockets there. Again, no surgery was done. We use laser and we use certain techniques that allow us. On the previous, on the left-right quadrant, the number 31 was extracted because it was beyond repair and there were some other issues. But number 30 went from 4.5 to 3 millimeters here. This is Louis. Louis has intermediate level of involvement on the genetic makeup. She's 58-year-old female. She came with bleeding, but her gums were not that inflamed. However, her good home care prevented further development. That's her pathogens before, that's her pathogens after. This is her probe, and you can see that on the upper right we have 5s and 4s and 6 on the lingual side. On the lower, also on the right, we can see that we have 6 and 5s. On the left lower we have periimplantitis with 5 and 4s, and that's after. Again, I'll show you before, and I'll show you after. This is a gentleman, this is a gentleman with periimplantitis on the upper left, and that's after the treatment. Look at his bleeding on the anterior lower, and it's gone. Well, we still have spots, but nothing compared to what it was before the treatment. I want to fly through because I'm looking at the clock, and the clock is not in my favor here, but I want you to see this case. This is Teresita, 61-year-old female. It's a case in progress. She has high predisposition to inflammatory disease. This is her pathology before treatment. She's still in treatment. This is her probing. For those people who are listening to me and looking at this is a nightmare. She has 4s and 6. She's bleeding profusely everywhere. She has a history of breast cancer in the past, which tells you about the immune system. She was exposed to mold and developed problems with her kidneys, lungs, liver, and colon. That tells you about her body resistance. And this is a very good example where systematic problems caused complete destruction of the gum tissue. No matter what she does, it doesn't get better. She also develops psoriasis lately. Why? Because her immune system is out of whack. Her immune system is fighting everything, including her skin. That's what she is now. Again, that's before, when she came in January of this year. This is July 9th. Look at the upper arch, look at the bleeding, those diamonds, red diamonds, all those spots were bleeding. Look at the upper arch now. Look at 6s, 6 millimeters, 7 millimeters pockets on the upper right, on the lingual. They're down to 3 and 2s. I want to go now, in the few minutes that left for me, I want to go through the financial aspect of the protocol. This is a comparative study of Dr. Winnick's practice, Dentistry for Health in New York, and I'm comparing here revenue from 2012 to 2013. The graph starts in March because if you look in the middle, Nicole Bach is one of the hygienists. She started at Dr. Winnick's practice in March of 2012. We did not have data before that. So you can see right here, can you see my cursor, Danny?
Yes, sir.
Yes. You can see here, this is Nicole's production per month in 2012. And she generated in that year, since she started in March, $120,000. That's her production. In 2013, I started working with Nicole about April, and after that, this is her production using the protocol. The numbers below right here indicate the change in percentage compared to the previous year, the same month. So in May, compared to the 2012, her production went 44%. In June, 137%. In July, 300%. In July of 2012, she was not using protocol. In July 2013, she was using protocol. 300% increase. Of course, this is a special month, and you'll see it throughout. Every month, these are percentages, and these are the numbers under protocol, without protocol. In 2013, starting in April, May, she generated, again, I put it here through April to December because that's when she started. She generated $300,000. That's her annual, if you compare January through December, and this is percentage of her increase. Nancy, another hygienist, I started with Nancy about a month after I started training Nicole, and Nancy picked up in June and gradually started going up. These are Nancy works 3 days a week, Nicole works 4 days a week. So the numbers are skewed, but the percentages are there. Because Nancy started later and she works less, she generated $222,000. In general, hygiene department, if you compare all of them, by the end of 2013, hygiene department generated $633,000, just 2 hygienists, improvement by 74%. The practice in general went from April to December, 30% increase. I want to probably skip through this. This is Nicole's. Let me fly through that very quickly. This is Nicole's production per month in January, working 4 days a week. Important part is not only to compare production per month as she goes into the May, which is the next one right here. Again, if you look at the previous slide, that's before she started using protocol. Look at production per month on the top. That's after she started using protocol. That's for July, as I showed you on the previous slide. This is important. Production per patient appointment. That's what Nicole is producing per each appointment, starting using protocol. And this is production per hour. You will see that production per appointment is more than production per hour. Reason being, as I told you before, Nicole determines how much time she will spend for each appointment. She determines her own time. But why would we care if she is bringing revenue to the practice? That's September through December. Yes, Danny.
I'm just saying it's an excellent point. You know, sometimes people think that time is money, and they're right. But the more, you know, it's better to do it right than do it quick, especially when you're dealing with patients. So I think it's an excellent point you're raising.
When you empower hygienists and you educate hygienists and you allow her to enjoy her work, she will bring the money. And of course, you have to share the money with the hygienist. Their reward is proportionate to their production.
Another important point, for sure.
So in November, she generated per hour $427. And per appointment, $452. That, by the way, Danny, can be compared to an associate working for another dentist. I'll go through Nancy, we don't have time. This is the slide that I want to look at. Everybody.
You're saying, though, that a hygienist can earn as much as an associate.
What's that?
You're saying a hygienist, a properly trained and practicing hygienist, can earn as much as an associate per hour or more?
Yes, yes. The answer is yes. Here's again Nancy working 3 days a week. This is in a little bit different chart comparing Nicole and, not comparing, but showing you Nicole's and Nancy's production. These are real people. These are not made up names. They're great hygienists in our practice. And look at Nicole. Let's start with Nicole. She was trained in March and April. She picked up in May. These are the numbers before. These are the numbers per month after. That's by the end of the year, 355,000.
The training only takes 2 months.
What's that?
You say the training really only took 2 months before they hit their stride.
Well, the training, it's a gradual training. And I'll get to it's a good point that you're bringing up, because before you start training hygienists, you have to make sure that the base is there. You have to build a platform, Danny. You cannot just throw hygiene department and allow it to prosper when the supporting staff is not there.
Sure.
We'll get to that.
Stage has to be set, sure.
So here, Nancy started, when I was finished with Nicole, I focused on Nancy. And Nancy started in June. And again, keeping in mind that she works 1 day less than Nicole, they're very on the same level. And Nancy generated $277,000 working 3 days a week. And together girls generated $633,000 by the end of the year. This is the chart explaining after hygienists are paid and after all the expenses related to health integration system. These are the net revenue that any practice will generate using protocol. Let me explain. This is the monthly production by hygienists. You see, here's one hygienist and here we have two hygienists. So if any hygienist properly trained will generate that amount of money per month, then the practice will generate that amount net during the same month after compensation of hygienist and HIS. And that will be the practice revenue net from the hygiene department from one hygienist, depending on how much she generates per month. Let's go back and look at Nicole. Starting in May, June, we see these numbers. Let's assume that Nicole is somewhere at 36. As a matter of fact, I have a number somewhere, but I believe it's about 36,000 on average per month. So based on this chart, Nicole is about here, between 35 and 40, which means that hygienists trained and working as Nicole will yield for the practice net about 250,000. Okay? Now let's look at the situation with two hygienists. Keep in mind, Nancy was working only 3 days. Let's take two hygienists working 4 days. You'll be between 70 and 80,000 production among two hygienists. Using the same logic, the practice will generate about 500,000 net per year. Now, using protocol, any given hygienist cannot have more than 120, maximum 150 patients per year. When they graduate their patients after treatment, they obviously pick up another new patient and lead them through treatment. But at any given time, they cannot have more than 150 patients. There are two ways to start this program in the practice. One is converting the existing patients, and that's what we did in Dr. Winnick's office. We reevaluated his existing patient base, and keeping in mind that 75 to 80% of people must be treated for periodontal disease because that's what they have, we brought a large amount of his existing patients into protocol, and Nicole was booked within 2 months. She could not have any more patients. That's when Nancy picked up. Now we hired a third hygienist because Nancy and Nicole are done. Which means that if the practice has, let's say, 2,000 patients, active patients, normal, healthy practice, you will need 3 hygienists from get-go in order to reevaluate your patients with a proper approach, as we did at Dr. Winnick's practice, and start doing that. Keep in mind that as you convert your patients into perio treatment, you have to start marketing and bringing patients from outside. You cannot just rely on those patients. At some point, they will be all treated, and they will go into maintenance mode. So the marketing for new patients must go parallel with conversion of your existing patients, and that's the key. So your well never dries out. But you don't have to rely on marketing from the beginning, from implementation of protocol, because you already have patient base ready to be converted. The first year, 2013, in Dr. Winnick's practice, the numbers that I showed you are based solely on conversion of his patients. Now, keeping in mind that one hygienist can have only 150 patients, and if your practice has 2,000 existing patients, then we go to the next chart. And the next chart, you will need 3 hygienists. And again, that's where the numbers are. If you're very strong practice and you have many associates, you can have 4 hygienists working at the same time, and you can generate up to $1 million net from hygiene department. Again, these numbers are based on Nicole and Nancy's performance. How to get there? That's a different story. Staff education and training. You have to start not from hygienists. You have to start, and we started in January of 2013, and Nicole started only protocol in late April, early May. Because you have to start from front desk and dental assistants. You have to explain and educate your supporting staff on oral soft tissue infection and inflammation. They have to understand correlation with systemic inflammation and influence of periodontal disease on the entire body. Why? Because they are receiving the phone calls. These are the people who will be asked by patients, what are you doing there? We heard about you, we read about you, we saw your website. Can you tell me a little bit more? The front desk cannot say no. And they have to understand how to process the patients and how to follow up and how to cooperate with hygienists and doctors. Then we talk about education of hygienists. That goes parallel. Again, oral soft tissue pathogens and their effect on the periodontal. Yes, they went to hygiene school, and yes, they're very smart people. But the research is moving so rapidly that we cannot rely on what they learned 4 or 5 years ago. So we must make sure that they know everything about pathogens in the oral cavity. Localized oral inflammation and patient susceptibility. Again, we touched briefly on patient susceptibility through genetic makeup. That was not taught in hygiene school. They have to know that. If they get the patient with Crohn's disease, they have to know what to expect. If they have cancer patient in their chair, they have to know how it will affect the treatment of their gums. Every patient is approached individually, just like in medical office. We have to forget the template of perioprophy. Gram-negatives, oral pathogens, and their effect on internal organs and tissues, that's the key, that's a must. Those guys are anaerobes. The moment they get through the bloodstream, and keep in mind, bloodstream in your mouth, all that dripping of blood, it's two-way street. If blood can come out, bacteria can get in. So when they get to the target organ or tissue, and they're anaerobes, they don't need oxygen for survival. They feel happy with all the nutrients there. They thrive. That's why we have to know what we're dealing with and what kind of species we're dealing with and what kind of antibiotics to apply. Generalized systemic inflammation. Again, why hygienists have to know that? Because they're treating the body. They're treating the patient. They're not treating the mouth. Oral systemic interrelationship, chicken and egg. Did diabetes cause inflammatory flare-up in the gum tissue? Or the gum tissue seeded the body to the point where pancreas gave up and they developed diabetes? Could it be that oral pathogens contributed to early diabetes? Speeded it up? Yes. So we treat the patient. We treat diabetes and oral inflammation at the same time. And that's where you have to work with the MD. This is the patient. You become the colleague of the medical doctor. You treat the patient at the same time. Salivary tests and their significance. We basically went through that before. This is a microscopic examination that we do in our practice. There are 4 panels, and for the lack of time, I don't want to dwell on it, but basically, if you have amoeba and you have a lot of spirochetes in somebody's mouth, I can guarantee you that the patient is either immune compromised, has some undergoing problem, or simply do not understand the value of the oral hygiene. So we do microscopic analysis. We don't just do the sputum. We agitate and we ask them to provide the sample, and then we look at the microscope and we discuss it. And again, those of you who will have access to this slide after the presentation, you can read the fine print there. But it leads the patient, and most importantly, when you do this test, hygienist sits with the patient and discuss the findings. Not the doctor. Don't waste doctor's time. Hygienists are smart enough to discuss the findings of microscopic examination because they do the test, they discuss the results, and they ask the patient, what do you want to do about it? We're not preaching, we're not pushing, we're not selling anything. When you go to a medical office, doctors don't sell you diseases. You have it. The same approach has to be here. The patient is sick. The patient is ill. What do you want to do about it? You tell me as a patient. This is another thing that we give to our patients. These are all the pathogens. This one is high-risk pathogens. And on the right side, it explains what organs it can target. This is based on myriads of articles, established scientific research showing which particular pathogen attacks what type of organ. These are moderate to low risk. We went through education. Now I want to talk about training of front desk staff. And Danny, this is very close to your heart. But patient communication is the key. Can you hear me, Danny?
Yes, can you hear me?
Yes. Patient communication is very important. The front desk has to be taught using scripts and rehearsing and rehearsing and rehearsing how to talk to patients, because this is not your regular dental office. This is your dental/medical. This is a health office. Let's call it healthcare office. So your front desk has to be up to par. Your patient's phone intake, that's another thing. You have to know what to talk about. Your patient scheduling. Again, this is not, you just don't go into the SoftDent or Dentrix and just plug in the patient. No, depending on the issue, the patient has to be scheduled accordingly. And again, in our office, protocol patients are scheduled by hygienists. If they have to cancel, only with permission of hygienist. Front desk personnel cannot cancel protocol patient because they don't know intimate details about the next visit. Intra-office communication. Every part of the office has to be on the same page, and people have to talk and communicate. Patient follow-up, communication and appointment confirmations. We kind of touched on that. Basic understanding of procedures and technology used by hygienists. Yes, front desk people must know technology in your office, because the questions from the patient will be about the treatment. And you cannot say to the patient, I don't know what laser does. You have to know. Training of dental assistants, very similar to the front, but more so because they are assisting hygienists. Let me explain about assistants. Protocol hygienists, just like clinicians, just like associates, they work with the patient. They work with the body, with the tissue. If they're not necessary, if they're not required to work on the patient, that job is for assistant. Let me explain again. Hygienist works with the tissue, with the patient, in the mouth of the patient. Anything outside of the mouth, assistant must do. They know how to do it. They are trained how to do it, just as they would assist the doctor. Inter-office communication is important. They have to know how to talk to the hygienist and to the front desk. And they have to know their tasks and responsibilities. Training of hygienists, patient communication, and developing trust, that's the key. Soft tissue laser application. Very few hygienists know how to use laser properly. That takes time and skills. Implementing protocol training for hygienists. I mentioned earlier, patient interview can last an hour more. By the time hygienists finish with patient interview, hygienists know everything about that patient. Family history, medical history, and not just on a piece of paper. They know everything about the patient. when the problem started, what triggered, what medications they're on, what diseases they have, what kind of surgeries they have in the past. Every piece of information, just like in a medical office, is important. Otherwise, they cannot set up the proper treatment plan. Patient assessment and testing, that's done. If first interview is done just talking to a patient, assessment is hands-on, and testing are done. Designing individualized treatment plan. Again, hygienist will design the treatment plan based on the patient interview, assessment, and results of the test. Then we have review of findings with the patients and presenting them with the treatment plan designed by hygienist and approved by the dentist. Then we go through sequential treatment procedures and their applications. Hygienists must be trained how to deviate if the treatment goes either way. Sometimes the treatment is so good that we can graduate the patient sooner than we anticipated. On the other hand, if the progress is not good, we have to look at it again and see what is getting in the way and talk to the MD and try to find out what is prohibiting us from successful treatment. Patient progress monitoring and communication during treatment, very important. And as important, patient follow-up, maintenance, and post-treatment communication. That's the health coaching that I was talking about. When patient is finished and graduated from the treatment, they still talk and communicate with the hygienist. The other big plus here, that these patients, after this treatment, will not go anywhere else. They're absolutely attached to their hygienist. Especially people who are predisposed genetically to inflammatory disease. The flare-up can happen anytime. They spend a lot of time and money. They don't want it to go to waste. They will immediately call hygienist and show up. Further education and protocol. We have to review, and we do review each new case and treatment plan. Review test results and presentation of the treatment plan to the patient. And we monitor and training and assisting hygienists how to proper schedule and how to utilize her time effectively. Advancing hygienists and practice. Because, as I said before, the science now is running, not walking, and every month I get more and more articles coming from everywhere. We have to be progressive. We have to introduce new treatments and new techniques and modalities as they become available. That will separate you from any other dental practice. We have to continue our education on periodontal disease and oral systemic correlation. Again, we have to look not only from dental point of view or periodontal point of view, but also from the medical point of view. What can influence oral condition? Review of research articles and scientific literature. Practice advancement. And again, this is exactly what we're doing in Dr. Winnick's practice. We have weekly professional meetings between dentists, hygienists, and dental assistants. We review and share complicated cases as a team, just as they do in medical offices when you have several doctors. We exchange ideas, experience, solutions, problems, whatever comes. It's brought to the table and we discuss it as a team. We also have weekly staff meetings that include the office manager, front desk, and everybody else. We review events of the past. If there were some mishaps, we have to know about it and plan how to avoid it in the future. We address current and future issues and concerns. And again, everything is brought to the table and we talk about it. and we discuss and plan new ideas, new procedures, and initiatives. Because as you recall, whenever we introduce something new into the practice, the front desk and assistants have to know everything about it and how to handle it.
So it's
Patient
an
referral.
interdisciplinary approach within the office. That's what you're really making, and I think it's a very important point.
Correct. You're absolutely right. Internal marketing. We talked about patient referrals by grateful and treated patients. We collect the testimonials that can be utilized in many venues, and Danny probably will be much better person to talk about different channels, how to utilize testimonials. For external marketing, obviously media. I'm talking about press releases. I'm talking about anything that you learn. Keep in mind, if you can spread the word on every new modality you implement into your practice as a press release, it will be picked up. Pretty soon the media will be waiting for your press release. You're giving them something to work on.
That's right, and you're positioning yourself as a noted authority in your area.
Exactly, exactly. Electronic communication, that's internet, landing pages, newsletters, and again, it has to be very smartly done and explaining why you are different and how you treat non-surgically periodontal disease. Events, open houses, in-office presentations, again, that can be done systematically, and I'm sure that Danny will enlighten you on many aspects of how to do it. Physicians and other healthcare providers. This is interdisciplinary outreach communication. That's very important for marketing. When you will send to a doctor in your area, and you'll be surprised how many patients who come to you, because they probably come within, let's say, 10-mile radius, depending on the area where you are, they probably go to the same MDs, and you'll see that very often several of your patients go into the same general practitioner or the same cardiologist. So if you'll start communicating with the cardiologist and you send him reports on your patients who are his patients as well, very soon he will start picking up on those symptoms in his other patients. And that cardiologist will start sending patients to you, even without you asking, because he will see the results of cooperative work. Points to consider. This program is not applicable to every practice. It will have certain limitations in an insurance-driven office. If the patient will ask you, does my insurance cover it? The answer is no. If that's all the patients want to know, you cannot help that patient. Part of our education and part of our conversion of existing patients in Dr. Winnick's practice is explaining to the patients the value of their health, the priorities, and we are talking about their bodies, not about their teeth or their gums. Unless they accept it and understand it, you cannot help them. So if somebody says, well, if it's not covered by my insurance, I cannot do it, then they cannot do it because they either really don't have means or their priority is somewhere else. And I don't have to tell you anecdotes in my own practice where I saw people who are planning European vacation and telling me about it, and they're so excited, and then I tell them about the findings, and at the end of the discussion they're saying, you know, doctor, I cannot afford it. Well, priorities. You can postpone your European trip for the entire family, because what we are doing for you can save you several years of life. but it's your priority. Dental providers must understand, accept, and practice within the oral systemic health paradigm. Unless you accept it, you cannot deliver the message to your patients. That's where you have to be clearly on the path of oral systemic health. You cannot convince anybody unless you truly believe in what you do. Dental providers must be open-minded, flexible, cooperative, and eager to implement changes in their practice. Again, we had a very unfortunate experience, and with permission of Dr. Winnick, I will say that he worked very successfully for many years with the office manager who would not accept the changes. And we had, unfortunately, we had to part with that office manager after more than 10 years working together with Dr. Winnick. We have to be open-minded, we have to be flexible, and eager to implement changes in our practice. That goes to everybody, to your hygienists, to your front desk, to your managers, and to your associates. In my practice, I had associates who would not accept it, and they were just sticks in my wheels. Providers must be open to granting authority to health and integration system to implement new modalities and train personnel. Obviously, if you cannot give us the green light to implement changes or implement philosophy, it will not work. Providers must be willing and able to allocate necessary funds in program development, equipment, and marketing. This is a very important point. With the revenue that I showed you before, with only 2 hygienists, and believe me, Nicole is only on the first leg of the journey. There is much more to protocol, and there is much more training for Nicole to take. That's why the graph does not stop at 40,000 per hygienist. So if this is the money that practice can net on perio department, then you have to be willing to take part of the money, either before or from the proceeds, and reinvest in developing your practice. Well, on that note, I think I exhausted my time. Danny?
Yes, sir, but it was time well spent indeed. We are, buddy, running up against the limit, but there are a couple of people that wanted to comment on their experience with you. I introduced them at the beginning of the talk today, and I know that Tammy has to catch a cab, so why don't we go with ladies first and have Tammy Kohlschmidt say a few words for us. Hello, Tammy. Tammy, are you there? I know you wanted to talk to us. Well, maybe we're not able to reach Tammy, or maybe because it ran so late she needed to go. But Reed, are you there? Because I know that you wanted also to share your experience with the protocol.
Reed?
Yeah, wait, I have Tammy. She was just out of the room. She's coming back right now.
Okay, great. Let Tammy speak. Hi, Tammy.
Thank you for having me here. This has been a wonderful presentation, and I'm happy to share my personal experiences with Dr. Slepak and with his Scottsdale protocols. So these protocols are very well designed. Hands down, they cover all the angles, everything in between, and they're for periodontal disease, but they're also for healthy patients. And I often find that there is a missing link there for our healthy patients. They do need some therapy as well. So Dr. Slepak's approach has been based on a medical model that treats the disease but also sustains the patient's health. And that's always been my focus, is sustainability. Dr. Slepak is beyond knowledgeable in periodontal disease and dental disease. He knows the oral systemic link inside and out. He is an extremely well-trained businessman. I worked closely with him, and I sit in awe of him quite often because of his business skills, and it's brought me to a much higher level. So I'm grateful for that. And he has a wonderful flair for teaching the staff. He's brought our assistants to a much higher level as implementers, and he's taken our hygienists into a higher, top-notch professional way of thinking. And that's been exciting for me. The healing result, it just goes without saying, I've witnessed in my patients, it's been beyond satisfactory. The results are visible, they're measurable, and again, they're sustainable, which has always been my focus, is sustainability. And our patients, they're grateful for the results that they've gotten. They feel the results and they see the results. So the other, I think, little part of this is for the hygienists themselves, because we are looking for a way to better ourselves and to elevate ourselves in the field, and that's what these Scottsdale protocols do, especially with Dr. Slepak's guidance. He takes us to a higher standard as a practitioner, and we become active participants in the patient's health care. We help bridge that gap between dentistry and medicine because we are in contact with the medical providers. And my mission has always been to help change people's lives. And I can say with much gratitude and with an open heart that Dr. Slepak has done that for me. He's changed my life. And that is one thing that I'm able to reflect and pass on to my patients, but also to other hygienists that I get involved with and help train. So I can only say that the most wonderful things about this program, and I'm very pleased to be a part of it, and I look forward to its progression and its growth. And on that note, I do have to run. I have to catch a cab. So thank you for having me, and I will see you all sometime soon. Bye-bye.
My pleasure.
Thank you, Tammy. Thank you very much. And I'm glad we had both Tammy and Reed to talk about Alexander, because as you might notice, Alexander likes to stick to the science and is quite modest, actually, although he has very little to be modest about. And I want to give Reed a chance to now share with us what working with Alexander is about. So go ahead, Reed, please.
Great. You know, I'm really enjoying the presentation. We've been together over about 1.5 years, and it's great to see all of our accomplishments. As you all know, oral systemic dentistry is in its infancy, similar to how aesthetic dentistry was in the 80s. And as a doctor and a businessman, I always consider the risks and benefits of any program that I bring into the practice. So let's look at the risks of undiagnosed perio disease. By not taking the next step and properly diagnosing perio disease, you will continue to leave hidden infections and inflammation in your patients. With the benefits of becoming a problem solver, you will achieve a higher standard of care for your patients. This could lead to rewards of improved dental medical outcomes and also increased revenue for the practice. Ask yourself the question, do your hygienists want to be in a rut and continue to be unfulfilled and burn out easily from the same daily mundane treatments? Or would you rather watch them become energized and excited by making a huge difference for your patients and for your practice? You know, the idea that perio is a lost leader to the practice is an incorrect assumption. The truth is that a well-developed perio program actually yields a profitable practice. Every hygiene program has the potential to reduce as much as your associates, as you've seen, and also your practice will become known to many people as making a true difference. Today, low tech is equivalent to no tech. And the diagnostics and treatment you will learn from Dr. Slepak are, in my opinion, high tech. Your patients will recommend you because you have exceeded their expectations. You know, from the start and even today after our tremendous growth, Dr. Slepak's hands-on approach continues to bring increased value to my perio department and my practice. I don't need to review what he has done. You've already experienced an overview of the tremendous change. His knowledge as a clinician, as someone who can motivate the staff into action, and as a businessman has enabled me to take a back seat from the business operations and focus on the growth of my perio department, which is very important to me. To me, this is priceless. I personally look forward to many more years with him. My feeling is that if you're going to ride this wave, you need a strong, sure-sighted captain, and that is Dr. Slepak.
Well, thanks a lot.
Thank you, Reed. That was very nice.
You're welcome.
Appreciate it. I look forward to seeing you both at the AASH meeting next month. We have a lot of questions, a very engaged group today, and I don't think we're going to have time to get through all the questions, but we've got about a dozen. What I will do is send them to Alexander, and along with who asked them, and maybe we can put together a little document that will answer all of them real quickly. Let me kind of run through, because then we've got some housekeeping to take care of about next month's event also. But first of all, Debbie Sabatini, who is a fellow AASH member, I think you know, both of you know her. She wanted to thank you for acknowledging the importance and potential of the dental hygienist. And as far as what you said, Reed, I think that was a really important point you raised too, which is this doesn't simply help patients more or help hygienists to earn a better living, but it really creates a more fulfilling career for them because they're, as you said, they're doing so much more, and they're being really asked to consult, diagnose, and treat a variety of conditions that their patients present with, which is fantastic. A lot of information regarding the correlation between the bodies. You know what, this is, just to summarize it, do you have any stats on how many practices are actually incorporating oral systemic approach when treating their patients, Alexander?
You asking me, Daniel?
Yeah, that was for you.
Well, I don't have a hard data, but nationwide, based on professional chat forums like Yahoo groups and other, and based on the attendees at many conferences that both you and I attended in the past, very few practices truly adopt the new paradigm of oral systemic. We all talk about it, but there are very few who actually able to implement it, unfortunately.
Yeah, sad but true, but you know, the people on this call are ahead of the curve. They're learning it, and I would guess that if you polled this audience, many more are at least beginning, if not being very successful with applying it. Another question, are you saying that the front desk person under your protocol cannot cancel any patient, or did you say they just cannot cancel a perio patient without having that patient talk to the hygienist?
No, the front desk cannot cancel or reschedule the protocol patient under protocol treatment.
Got it. Once you're in the protocol.
Every next step is calculated and designed by hygienists. So the timing of the next visit is critical.
Mm-hmm.
So if the patient says, I cannot come today, I will come in 2 weeks,
sure,
it might reverse the treatment.
Right. And that doesn't mean that the front desk just doesn't say, I can't do it. They have to give the why, because you never want to fight or argue with the patient. You want them to see why it's in their interest to do it your way, basically.
Oh, no. There is no discussion. They say, of course, yes, Nicole will call you back, and you will schedule with Nicole.
Right. I can help you with that. I'll have Nicole call you back. Not, I can't do it. I'll have Nicole call you back.
No, you don't even say you cannot do it.
I understand.
Thank you, Danny, very much for calling. I will make sure that Nicole calls you, and you will reschedule with Nicole. That's it.
Great. Another question, are you addressing nutrition, and if so, how?
Yes, we do address nutrition. That's the question to Dr. Winnick, because Dr. Winnick is a world-renowned holistic dentist, and he implements nutrition in the practice.
Okay.
So, Reed, are you there?
Yes, the building blocks of any successful perio program in my world, in my belief, starts with good and proper nutrition. And we are actually able to use the genetic test to help us determine if the nutrition for that patient is working. So to answer your question quickly, yes, nutrition is very important, and we do implement it.
Great. And also what I'm hearing is that there's, Alexander has a specific protocol that he introduces for hygiene. That doesn't mean that it's to the exclusion of other modalities that a practice may wish to practice or introduce. There's, I suspect, some room for some flexibility, variation on a theme perhaps. There are many management consulting companies offering their services to increase practice performance and productivity. How is this different from those?
That's an interesting question. Well, first of all, we're not about tightening the practice operation or streamlining performance. We are more introducing the completely new modality and bringing additional revenue stream. The other thing is that we do not come in for several weeks and just train employees and leave them to carry on their own. We stay with the practice every step of the way, and as time goes by, we're taking program to another level. It's an ongoing process. Our protocols have several modules within them, and each next level can be implemented only when the previous one is completed. So we stay with the practice, and we help. I'm working with Dr. Winnick for a year and a half now. That's the difference.
With all due respect to Dr. Slepak, he's tightened us up plenty. He continues to tighten us up, and I'm sure he'll tighten us up even more.
Mm-hmm. He runs a tight ship, that captain, doesn't he?
He does. He does.
Okay. Fantastic. All righty. Well, that's all we've got time for in terms of questions. I do want to acknowledge Diane and Tony and Bill and Steve and Crendel for submitting their questions. I will submit them to Dr. Slepak, and he will answer them directly with you. I want to thank you very much, Alexander, for delivering on what I promised that you would, which is a very stimulating, informative, and I think information-packed presentation, as well as for the offer for our attendees to learn more about how they can create a periodontal powerhouse in their practice. In a few days, you will receive an email with instructions on how to receive your 2 hours of CE credit. And I want you to please mark your calendars for our next webcast, which will be Tuesday, September 23rd at 6 p.m. Central Time, which will allow me enough time to pack up and leave and head out for the AASH meeting in St. Louis a couple of days following. Now, Dr. Charles Blair was originally scheduled to speak, but had to reschedule for January. So we simply swapped our January and September presenters, which was not difficult to do because January's speaker was to be none other than yours truly. That's right. Next month, I'll be taking off my hosting hat and stepping onto the podium to present Master the Art of First Impressions, which Alexander alluded to briefly. Regular Practice Perfection webcast attendees are already well on their way to mastering the 3 C's, as I call them, of the oral systemic practice. That is, mastery of the clinical, collaborative, and communication components. Next month's webcast helps complete this process by ensuring that you and your team effectively and consistently connect with prospective patients and additions to your referral network. It's this all too frequent disconnect at a critical stage in the doctor-patient relationship that the Art of First Impressions will address. So be sure to watch your email for an invitation, or you can go right now to the practiceperfection.com website and register. Until then, this is Danny Bobrow thanking you for your continued commitment to practice perfection. Thank you, Reed. Thank you, Tammy, and especially thank you, Alexander. Goodbye, everybody.
Goodbye, Danny. Bye-bye.
Goodbye.